Ladies and gentlemen, I am Katyayani and I welcome you all to this very special panel discussion on advances in breast cancer and the future of prognostic testing.
Rayo, please tell Mama
I'd like
to
to
not
thank
shout.
Zydus for helping us put this session together. Join me in welcoming our distinguished panelists for today. We have with us Dr. P.K. Julka, Vice Chairman, Medical Oncology, Max Institute of Cancer Care, Delhi. Thank you so much, Doctor, for joining us today.
Thank you very much.
We have Dr. Manjiri Bakre, founder CanAssist Breast. Thank you, Doctor, for joining us today.
Hi, thanks for having me. It's founder of Oncostem Diagnostics.
Okay, sorry.
Yeah,
My
no problem.
Right. We have with us Dr. Bharath Rangarajan, Consultant Medical Oncology, Kovai Medical Center and Hospital, Coimbatore. Thank you, Dr. Bharath, for joining. And we would also be shortly joined by Dr. Vashishth Maniar, Consultant Medical Oncology, Mumbai Oncocare Center, Mumbai. And our session moderator for today, Dr. Vamsi Krishna, Director, Department of Medical Oncology, AIG Hospitals, Hyderabad. Thank you so much, Dr. Krishna, for joining us today. And I hand over the session to you now. Thank you so much.
Thank you so much, Katyani, and welcome to all the panelists. We have been discussing a lot of oncology in all its aspects, and I think today is a good time to discuss how we would be looking at oncology, especially the breast cancer therapy presently and in the future. Of course, there would be a bit of special emphasis on the role of prognostic markers and the role of testing for these prognostic tissue tests for breast cancer, specifically for seeing what is the role of chemotherapy and perhaps more importantly, how to avoid this chemotherapy in a few selected patients. So what we would follow a pattern is not going via any fixed case studies. Let's not go with a slides. Just let's have a discussion on where we see breast cancer treatment evolving and how we can manage to treat these breast cancers in a more personalized way. So no slideshow for anyone, no case discussions, and no really breaking the head on how to decide each individual case. So if I can start off with you, Dr. Julka, sir, you have been a senior doyen of oncology for the last several years, and you have seen all the change that has happened in oncology in the last 30 years. So what, according to you, has been the biggest change in management of breast cancer in the past, say, 30, 40 years?
In the past, my past journey starts from 1970s. You know, when I started treating breast cancer, and I don't know how many were born that time. It was
I wasn't.
late 70s, and all of the patients used to get, surgery. That was mastectomy. All the patients used to get CMF chemotherapy. All the patients used to get, hormone therapy in the form of tamoxifen. So there was no ER, PR, HER, all those molecular markers. There were no markers at all. In 1990s, we found that markers have come, which were hormone receptors, and then HER2 came. So all these markers we started treating according to these markers. The patients were treated. And after 2000 and after 2010, most likely, the more markers came into being, that molecular profiling was done. I always used to say that we have a molecular horoscope for most of our patients. So, molecular horoscope meant which mutations are there. For example, hormone receptor positive, we had only hormones earlier. Now we have CDK4/6 inhibitors in the metastatic setting, and now we are having it in the early stage setting also. So, and then in hormone receptor positive, we have PI3 kinase mutations also, which are cause of resistance. Then we have ESR1 mutations, and later on we'll be seeing ESR1 fusions also. So what I'm saying, it's a molecular based therapy. And now where are we moving to? In the future, we are moving to antibody drug conjugates. And you must have read in the ESMO this year, it was the more emphasis was on antibody drug conjugates. And in our center also, we have used trastuzumab deruxtecan for HER low and post TDM also. And so, based on these markers, we are using these, like antibody drug conjugates, which are giving good results. Sacituzumab is another one for triple negative and ER positive. Then we have certain other markers which are coming up, and datopotamab has come now, deruxtecan, for again, emphasis was given in this ESMO on this new antibody drug conjugate. So all these drugs are available outside, but fortunately or unfortunately, they are not available in India, and people are asking for it, and some people can import it. Those who can import it, they get it. Those who can't import it, we try to do something else, cheaper alternatives. But treatment is becoming costlier day by day, which I feel. And another important thing is, earlier we used to do oncotype DX in most of the cases. And here in AIMS, I used to do Oncotype DX most of the cases because they used to get reimbursement. Now here we have CanAssist also. We have Dr. Manjiri also here. She will be highlighting. So with CanAssist also, we are, helped in the form that chemo can be avoided and patient gets only radiation and hormone therapy, which is much cheaper than and less toxic than other modalities. So I think there is a great future for breast cancer, for all the cancers, and especially for breast cancer. A great future in the molecular biology of breast cancer. And the more we understand the biology of breast cancer, the more we'll be able to treat them and give good results in all the cases, even in triple negative or even in triple positive cases.
I think fantastic. I
Thank
think 3 minutes you have covered the right from the start of the cancer to the exact tropoion study. Also, you have highlighted. So fantastic. I
I
think
thought,
there's a lot to unpick in what you have said. One by one, we
yes,
just start discussing this. Dr. Bharath, you always keep telling me that the maximum reading we have done is after the DMV passed. I remember these words of yours when the last the second role of ESMO was just like a refresher course for us and a relearning for us. What, according to you, has been the change, I would say, in breast cancer? Obviously, there can't be one. But some of the biggest changes which we have seen in the last 4 or 5 years in breast cancer management.
Vamsi, can you just repeat that question? Your voice was breaking.
I'm so sorry. I was saying, what, according to you, has been the biggest change or the biggest changes in breast cancer management that you can think of in the last 4 or 5 years? And let me be more specific. Something that impacts us in India here. Because, like Sir was saying, a lot of drugs are not available for us. So, we can talk about it. But what has been impactful for Indian patients?
That is, when you're asking specifically for Indian patients, I mean, I can't put a finger on anything specific, but a few things, when not just 4 to 5 years, when you look at the landscape of breast cancer, I think, apart from the ERPR coming, the 2000s, 1990s, 2000s, HER2 as, discovery of HER2, that's very important. And along that, towards 2008, when we had that classification of luminal A, luminal B, basal type, that actually pushed forward our understanding. And then, when we had to look at breast biopsies as biopsies with high proliferative markers and biopsies with low proliferative markers, whether it's mama print or whether it's oncotype dx, whether it is Dr. Manjiri Bakre's platform of CanAssist. So, to look at these things, as categorization, that is what, but that has not happened in the last 4 to 5 years. last 4 to 5 years, as sir said, I think, it is antibody drug conjugate, ADCs, that are, going to change how we are looking at, be it triple negative with sacituzumab govitecan, or be it HER2 poor or HER2 low tumors with trastuzumab deruxtecan, and of course the evergreen thing, whether it works or not, immunotherapy. So these are the things that comes to the top of the mind. But India specifically, you're asking, Dr. Manjiri is there. She is a better person to answer because she has a platform which is relevant to India. Second, I think the metronomic protocols that are coming out of TMH for patients who can't afford all these ADCs and everything is very important.
Fantastic. So for me, one of the biggest things, which I don't know if everyone agrees with me or not, and this is a much maligned industry of India. We keep saying that pharmaceuticals drugs are expensive, but very illuminating. The costs of drugs in India are actually 1/10 the cost of still drugs in abroad. So for me, that's one
Absolutely.
big thing. You consider
Absolutely.
the paper from the TMH paper in 2011-12, I remember, said only 6% of patients are getting trastuzumab. And I think in today our practice, everyone's practice, it at least 60 to 70% end up getting trastuzumab. That's a huge change that
Yes,
has happened, which
yes, and if you look at the West, Vamshi, you're very right. A drug like lenalidomide is
yes,
unaffordable to people in US. You cannot afford
yes, yes,
lenalidomide, and
yeah,
we write lenalidomide as if it is, tap water. We write
correct,
lenalidomide,
correct.
and patients go and buy it from some shop. There are so many generics. So you're right. Trastuzumab is another drug which is now available. If the patient really negotiates, he can get it for 14-15,000 a dose
Yeah,
also. So it's
correct,
really a
correct. No,
huge
that is
huge
something we
thing.
have to give credit to the Indian pharma industry. Sometimes I know they are kind of vilified for a lot of things, some of which are justified, but sometimes we should give them credit as well. And on that note, let's see nicely into this, calling Dr. Manjiri. And really, everyone is saying the same thing. This is one of the few Indian platforms and innovations that has come around in the last few years. So just talk us to the journey of that. What made you look for this kind of a thing? Saying everyone was saying oncotype. Dr. Julka says, "Oh, I'm happy doing oncotype," but then you had the conviction to put your money where the thought was and bring out a test like CanAssist. So just walk us through that.
Sure. Yes. Yeah. So I was actually in a cushy job in a MNC. When I'd spoken to so many doctors, and I've had a close relative who was diagnosed with breast cancer, and there was no way of assessing her. Pro- chemotherapy is required. She was scared, and then when she tried to assess, that's when I realized about Oncotype DX, and then the cost just was prohibitive. And this was really back in 2010, and so I thought, why don't we consider something like this, develop something like this for our own patients. And that was really the root cause. And I spoke to many clinicians, and I got really positive feedback from clinicians saying, yes, we understand the need of such prognostic tests, but the existing ones, like Oncotype DX, is very expensive. So, but I said, if I come up with a test tomorrow, would you be willing to use it? They say, yes, we do see the need for such tests, so we'll certainly use it. And that was really, because no matter what you develop, in the end, it should be useful to doctors and patients. And so that was really why I really spoke to many clinicians. And once this was realized, I really put all my blood, sweat, and tears in this. And thanks to a good team, and many advisors from all of you, that we have been able to develop this kind of a test. But to begin with, I had literally no idea whether I could even come up with a test like this, because it does take a lot of research, and statistical model development could fail, validation could fail, and then but everything really fell in place. And now our focus is only to really keep on extending the like kind of validating the test in different countries, etc., just to extend the market and usability of the test.
It's really inspiring to hear you discuss that, because I'm sure there were points when you would have said, look, let's just give it up. This is not going to work. But seriously, because, many times when the product came around, I think Dr. Bharath and Dr. Julka sir will agree with me. We had our own skepticism to begin with. Is this as effective
Yes.
as doing an oncotype? Is it as validated? In fact, even today, we do get such questions being asked. So let me start with Dr. Julka. Do you now routinely believe it can be done for all patients, or are you still looking at subsets where the CanAssist data has been, kind of validated? So would you use it
Yes,
across the board?
actually, yes. Very nice question, because there was lot of chaos in my mind, whether to use this or not. Whether, because one is patient centric, and if the patient asks, is it validated? I have started using Oncotype, this CanAssist also now, and I find it to be very useful. And I have seen results in a few cases only, because not many cases, but in a few cases where the score was low and we could do away with chemotherapy. So I started believing, and now what I am doing is I am comparing it with Oncotype DX, because I was told by CanAssist people that we can do that test for you and compare CanAssist with Oncotype DX, and then give you the result whether it is validated to that level or not. Because earlier we didn't have any test, we had mostly Oncotype DX, and we have so many other tests coming up now. But still, CanAssist, everybody says, give me a cheaper alternative. So obviously, you can't say no to anybody. But CanAssist has really done wonder. I must congratulate Dr. Bakre, so that this test has become available to the Indian audience or Indian patients. And so we are using quite often now CanAssist, and we find it very useful in prognosticating the patient and in avoiding chemotherapy to most of our patients. And we have seen long survivors also. Not that long, because I was in AIMS earlier, and I have come after superannuating from AIMS as a dean of AIMS. So now I'm with Max. So I have here only 7 years experience in Max. So 7 years, over these 7 years, I've seen the CanAssist has worked and worked well, and I must congratulate her.
Thank you.
So I think you have let loose a cat out of the bag about your getting extra tests done, which is not available for people like me and Dr. Bharath, I think. But anyway, we will ignore that point and move on to Dr. Bharath. Dr. Bharath, again, let's play the devil's advocate. The data has come from mainly the node negative subgroup, and that was published recently. I think after that publication, a lot of us did get a bit more confidence on the product, and we have started using it. At least in my case, I have started using it more and more. Let me ask you a related question. Are we really seeing these early breast cancers more as compared to before?
Yes, that part I have no doubt. We are seeing more early breast cancers, but then remember, I work in a specific center where the
Yeah.
breast program, the breast clinic is, is a it is one of the best breast centers in the country. The breast imaging papers that come out of KMCH are unique. They help in forming the guidelines. The Radiology Society of India and the breast imaging conference is going on as we speak. So the algorithms that are developed in KMCH breast clinic are adopted even in textbooks. So although most people don't know about it, so here there is a lot of breast radiology going on, not from the oncology side, from the radiology side. So I see a lot of early breast cancers. But I'm looking at your question from two perspectives. One is, as Dr. Manjiri said, for us, Oncotype DX was very expensive for a very long time, and we could not afford to do it. At least in my practice, 95% or 98% of my patients couldn't afford it. So we have sort of developed our own the clinical algorithms, the predict score, the Maggie equation, and we have decided. And the thing is, now I'm 50 years old. Of course, I'm not as old as Julka sir, but after a long 15 years or 16 years of practice, I feel that, as an older person, I'm confident in telling a patient, look, you've got a 2 or 3% advantage of taking chemotherapy, but chuck that advantage. It doesn't matter. You don't need it. Throw it away. you just take hormones, we'll see you don't have a great overall survival advantage. It is DFS in node negatives. So that sort of confidence builds up, I think, with time. That may be overconfidence, that may be false confidence, but I am quite comfortable on clinical grounds on the adjuvant online, the predict score, the Maggie equation to avoid. So I use these tests when the patient can afford them. If they can afford an oncotype DX, oncotype DX. If they can't afford, definitely CanAssist. But if it's not a great thing, I say okay, fine, take 4 cycles of TC chemotherapy and then go ahead with the hormones. So that is not too difficult. But one thing is, that's because we are sort of ignoring the ill effects of chemotherapy. If it's actually affordable, like CanAssist is, and validated, especially in the node positive also in the next subset, we would definitely be avoiding chemotherapy for more and more women. It's not it's very easy to sit in the oncologist chair and give chemotherapy. You ask the patient the difficulties of chemotherapy, the difficulties. So
I
uh,
know.
my threshold for avoiding chemotherapy is quite high. My threshold for avoiding aromatase inhibitors in postmenopausal women is quite high. My threshold for avoiding ovarian function suppression in premenopausal women is quite high. But that, I think, is a very individual thing. That's not guideline. The guidelines would say do OFS for everybody, give AI for everybody. But that apart, I think that these tests are very useful. We must be, Dr. Manjiri, I'm sure will be validating it more in a node positive subset cohort very soon. We'll be more comfortable using. But as of now, node positives, most of women, unless they're very frail, they do get chemotherapy. So,
Yeah.
in spite of the response rates data.
So actually, I am very interested in this because the latest EBCTC meta-analysis kind of threw a lot of shade on it. I mean, it never really showed that you shouldn't give 4, but somehow the interpretation doing the rounds is that everybody deserves to get AC and T. I personally don't agree with that,
I
but
don't agree
somehow
with
that
that.
seems to be a, I know, Doctor, I don't know, I don't know, Julka agrees with this, but somehow that seems to be the prevailing wisdom now among a lot of my younger colleagues who say that, oh, that's, you have to give 8. So either you give nothing or you give all 8 doses, which is a bit difficult to digest, especially considering the side effects that you end up seeing with anthracycline, and not just the cardia, the whole mucositis, the entire kind of other toxicities that you're seeing. So, Dr. Manjiri, to you this question, because we are now kind of okay. Node negative, yes, there is good data, we have a paper, we are satisfied. And again, in my center, we are having a good, better screening program, so we are seeing more of these early breast cancers. So we are actually interested in doing these tests. But what about that postmenopausal node positive, or the premenopausal women who are again maybe a microscopic node or just a single node? How comfortable should we be in using a CanAssist there? If you could just let us know on your based on your testing.
Sure. Yes, I completely agree. I mean, we have to continue to strengthen our own data, and that's what we focus on. So one of the things we did in the recent past was, predict for 10-year recurrences using the team trial. So that was a prospective randomized trial in Europe, a completed trial, and we did a 10-year predictions in a blinded manner. So that shows the ability of CanAssist to predict for 10 years also recurrences. The other thing we are working on, a manuscript that we are working on, is ability of CanAssist breast to predict risk of recurrence in what are called clinically low risk or clinically high risk. So I understand, because you always have clinicians always have a way of judging the disease, and that is absolutely correct way to do. But what we have seen interestingly, and this is, I mean, all of these questions we are answering because you have asked us all these questions. So it's really the constructive dialogue with you all is really what's helpful. So many times when we would give this presentation, clinicians have asked, how does CanAssist breast work in clinically low risk? So these are all T1 N0 patients, T1 T2 N0 patients, irrespective of age. Many of them are, of course, postmenopausal, where the chemotherapy has been avoided. And what we have found is about 8 to 12% patients in this clinically low risk disease who are actually at high risk as per CanAssist breast, and their DMFS is lower, or even IDFS. So this goes to show that you need to go beyond the clinical parameters and ERPR HER2 parameters. And so we also did we also looked at low key 67, that is under 5%. And even in these patients which have low Ki67, they were, I can just point out the data, they were significantly, let me just say the exact number so that, yeah, so low Ki67, we had, where is that slide? Yeah. Under 5% Ki67, we had about the high risk patients which were stratified by CanAssist breast as high risk had a DRFI of 84%. So that, and they were 12%. So that just one thing shows that even when Ki67 is low, there can be high risk disease. Now coming to a node positive question, yes, that's a question that that bothers all of us, because in invariably in India we have one node positive patients. So we have validated CanAssist breast in 1 to 3 node positive patients, primarily N1 disease, and that number is about 1,300 patients. And in that 1,300 patient total cohort in node positive disease, we have seen that CanAssist breast is able to segregate about, let me tell you once again the exact number. Yeah. So the in the node positive disease, CanAssist breast segregated 51% patients as low risk, and they had DMFS of 92%. So, I'm sure your next question is, so did they get chemotherapy? And so we did that analysis also. So in node positive patients, we segregated the analysis in chemoendocrine therapy and endocrine therapy alone. And in that endocrine therapy alone, we have about 450 patients, and the DMFS in the low risk patients is 91%. And that's about 60% of those 445 patients fell in our low risk, and they had DMFS of 91%, whereas the high risk patients were at 83%. This is all without chemotherapy. This is only endocrine therapy alone patients. So these are the things that that we feel confident about, and we have so far in a prospective scenario, in clinical real world data. Out of now, CanAssist breast has been used for more than 4,500 patients in the last 6 years, and about 18 to 20% have been node positive N1 disease. Now, of course, in the very first year of our sales, we did not get node positive patients. They were primarily N0 patients, but many of them who were low risk have finished 5 years. They have been auto rickshaw drivers' wives or juice centers' sister, all those patients. And those low risk patients who have avoided chemotherapy are doing well. So we are following patients as we speak, even the node positive who came more like maybe 2-3 years later, 2018, 2019. They haven't finished 5 years, but we are working to follow those patients, and we'll be the first ones to show you guys the data on how do the node positive patients who were probably, who did come out as low risk, avoided chemo, how are they doing 5 years later?
Interesting data, because we would look forward to this data. This is something that will give us the confidence, because right now we do have the oncotype data, and that does kind of guide us when there is a node positive. So Dr. Julka sir, where are you now in using in node positives and in premenopausal, say a node negative? Premenopausal node negative, are you comfortable with CanAssist, or what about the postmenopausal node positive? Two subsets specifically
Postmenopausal node negative.
Node positive, sir. Node positive. Okay. What about node positive?
Node
positive, are you?
I'm still not very comfortable.
Still not very comfortable. Okay.
Very comfortable, because node positive, I go more on the clinical aspect of disease, because we have been clinicians right from the beginning, and I examine each and every patient myself. And even, in MD Anderson, they used to joke around in breast clinic that Dr. Julka will find some node or the other in the axilla. I told them my hand is MRI. You do CT scan and MRI to find out a node in the axilla. I can find out with my own hands. So because of practicing here in AIMS, so we had a lot of patients, and experience, tells you how to examine the nodes. And even in the examination, I used to ask the doctors in MD, DM, that how do you examine the nodes? First tell me, So this is how, what I'm saying in node positive, I'm still not very comfortable. As Dr. Manjiri was saying, that node positive, they will be giving us the data in 1 to 3 nodes. And first, let us have that data first. And once we know that 1 to 3 nodes, this works similar way as Oncotype DX or any other uh, markers. So then after seeing the data, we'll be more comfortable. But at present, seeing clinically, then we go in for chemotherapy, especially in premenopausal age group. And our exponder trial, you have seen in all the trials where they have given the score to be in between. Earlier Oncotype DX used to give the intermediate score, and I used to give chemo in most of the cases where the patient was young, less than 40 years, even if Oncotype DX was little lower. you know like earlier we had 18 score, and if it was
Yes.
1920, I used to give chemotherapy, not to take any risk with the
Yeah.
younger patient, because younger the patient, more aggressive is the tumor, and it is a bad prognostic factor. So that, keeping that in mind, the clinical picture, I used to give chemotherapy to most of our patients. That was the thing. And if we get the data from Manjiri, then I think we'll be more, confident in using this for node positive cases.
Fantastic. So, Dr. Bharat, a quick question. We do have these scenarios where we get a patient who is 66 years, 67-year old, 3 nodes positive, and we want to give chemo there because we feel it's a clinical high risk. And we do an oncotype or a CanAssist, and we find it says low risk. We are tempted to still give chemo. Are you still facing such scenarios, and how do you settle it? I think you're mute, Dr. Bharat. I can't hear you.
Sorry. Not
Yeah.
if the patient is 65 and it's node
Hmm.
positive. See, the thing is, less than 40, I would err towards giving chemotherapy if for anything that is T2 and above. If it's T1A, T1B, T1A, of course, we won't give T1B, T1C, and patient really wants to avoid chemotherapy, then I may go with one of the predict scores, either Oncotype or CanAssist, and avoid chemotherapy in less than 40. But T2 and above, usually younger patient, I would give less than 40. 40 to 50 premenopausal, again my threshold for giving chemotherapy would be low, and if the Oncotype DX or the CanAssist says that it's low risk, I would avoid the chemotherapy. But see,
Okay.
if you've done, I would avoid the chemotherapy. So there, my thing is to avoid chemotherapy, not to give, unless the CanAssist pushes me to, even if it's T2. Now, node positive, anybody less than 50, anybody who is premenopausal, I would still give node positive. I would give chemotherapy. I won't do a score in that situation and confuse myself on what to do. Now, 65, node positive, 1 to 3, N1. There, if I've done a score, I would respect the score. The Respondex says it's a randomized trial, NEGM publication. It says that there is a cutoff. And 25 is a good cutoff. Postmenopausal N1, 65 years old, I'm comfortable avoiding chemotherapy in a low risk. If she fulfills all that criteria for a 65-year-old.
And I think this is a very important point which all listeners should say. If you have done a test, respect the test. Don't
Respect
do
the
the
test.
test and then say, I don't, I think this test should not have been done, or I don't respect the value of the
Exactly.
test. I think
So
that's a very,
I
very
try not to
important
do
point you have
test
said.
till less than 40s.
Exactly. So I think the
Less
way
than
we put
40,
it
I
is
try not to do the test.
perfect. I think you can simply say, look, I don't want to do the test. It'll just confuse me. Let's just go ahead and give you the chemo or not give you the chemo
Not
as it
give you
is.
the chemo.
Perfect. So, Dr. Bharath, can I come to one more interesting point? Is we are now getting data saying that if you have node positive, just give adjuvant CDK for all. We are seeing one side of the story where we say let's avoid chemotherapy by doing a prognostic test. But then you have the other side where it says let's give CDK to everyone who is node positive. And even if you get a report which says a Ki67 is slightly high, you're fine to even go ahead with the Abima or with the Ribo, as the case may be. So, it's a bit difficult to reconcile these two slightly contrasting approaches. What are your thoughts on that? Are you sold on the CDK4 story, or would you say, okay, I'll do a CanAssist or a Oncotype, say it's low risk, I'll avoid everything? It's a tough question. There's no answer. I know that, but I just want to hear your
There's
thoughts
no
on it.
there's no answer. But if you look at the Monarch E data, The abemaciclib, the curves are continuing to separate, and node positive curves are continuing to separate. We still don't have mature overall survival data, but the IDFS data is now, I think, at around 7% difference or 8% difference,
0.8.
7% difference, and the curves are separating, continuing to separate. They're not, closing down. So we have to wait for the IDFS data. But I mean, on OS data. But IDFS is an important endpoint, and in node positive, I think, irrespective of whether we've given chemotherapy or we've not given chemotherapy, if we've given chemotherapy, it becomes high risk automatic. That's why we've given. Either based on clinical grounds or based on one of the risk scoring, then I would go for the abemaciclib at this point. If it's a postmenopausal woman with node positive, at this point of time, the data seems to be driving towards. Of course, we don't know how the OS, but looking at the curve continuing to separate, I feel that there may be. And Abema is now for 2 years, unlike the Palbase, which was for 1 year. So Natalie, I think, is 3 years. So let's wait. As of now, not 3 years. So I think Abema data, as of now, convinces me to give for node positive high risk women, irrespective of scores.
Okay, I think you and I in a minority of people who believe in this. There are a lot of detractors out there. We'll not get into that argument. Luckily, nobody in our panel today is in that side.
I am sure that they have a point. In oncology, we can't say. See, the problem with when you're talking about this, when we are talking about risk scoring, there are so many things. In a premenopausal woman, whether you use tamoxifen, OFS with tamoxifen, which is showing the overall survival data, or OFS with exemestane, which is seems to be slightly numerically inferior to OFS plus tamoxifen in premenopausal. Would you use 5 years or 10 years of hormones, especially in the postmenopausal women? Okay, is it Atom or Atlas? Now, would you use a switch therapy in postmenopausal women? Would you use abemaciclib in perimenopausal? Would you use abemaciclib in postmenopausal women? So the duration of endocrine therapy, the use of OFS, everything is associated with what? 2%, 3% IDFS benefit, overall survival around 2%, 3%. That is the benefit. That's all there is. So, if anybody says I don't believe in it, I think we have to respect that. And, you sort of have to, give what you feel is doing the right thing and what is fitting into the budget of the patient.
Excellent. I think you are really talking your age now, what you spoke about earlier. Huh? So, but really nice to hear this. So, Dr. Manjiri, I think this is something which, again, a lot of us are going to start asking. Can we have a test similar to CanAssist for deciding on endocrine sensitive? Because that is something which is, again, going to be very interesting to going ahead. So, if I can ask you, any thoughts of expanding CanAssist to beyond only chemotherapy? Are you developing any similar tests for, say, endocrine sensitivity or any other type of tests you're doing? Where is CanAssist going from here?
Yeah, so the short answer is for endocrine sensitivity, it's harder to develop primarily because the data sets available to develop it on. So we need to have the kind of data sets where patients, younger patients may have been treated with only one drug, only tamoxifen or only AI, or and then followed them for 5 years. And but depending on the patient's menopausal status, we switch and we change. Sometimes they progress on tamoxifen, so we switch. So that is the nuance of developing something. But having said that, it's a very interesting question, really touches my heart, and I would love to develop something. I do have thoughts in my mind, but we need the money in the pocket to really implement it, in short. So would love to do that, but today I have only thoughts. And but what we could do potentially is prospective trials based on low risk a patient, whether they are younger or older. I mean, if we can do something like switching, or we can think through a design of the trial and implement it and assess it, or maybe in neoadjuvant setting, if the patient is low risk, the chemotherapy may not shrink the tumor, and in that case give neoadjuvant hormone therapy and assess the response of the tumor. Some such smart trials if we do, and maybe couple them with CDK4/6 inhibitors. So that's the trial I'm really keen to do also, and see. I mean, of course, that will be in adjuvant setting, but we can think through those issues, or those very important questions we can try to solve by doing smart trials prospectively, is my first thought that comes to mind. And having said that, I am working on additional tests. We are working on COSTEM, but not at this point on this endocrine sensitivity, etc., because that it has many angles to it, and we need to cover all of them to really give you a comprehensive test, whether it is ESR mutations, or what is it that really leads to this endocrine resistance, and why is patient progressing on that. So there are multiple angles, and we want to look at each of those. So that's going to take a little bit of time, but meanwhile we can solve it. And but to answer your premenopausal question, since all of you touched upon lymph node negative and lymph node positive premenopausal, I wanted to also give you highlight that we have data on premenopausal. We have recently did subgroup analysis of under 48. That's what we call premenopausal under 48. And in this pair, we have about 400 patients who have lymph node negative disease. This is retrospective, and the low risk patients are at 94%, and DMFS, and high risk at 83%. And lymph node positive premenopausal patients also we have around 300, almost 285 to be exact 285 patients, and out of that the low risk patients DMFS is at 91%, and that's only 46% of the total patients. So we do see a drop the moment there is node positivity in premenopausal patients, but the patients which the test picks as low risk definitely have a better DRFI than the high risk patients. It's always consistently significant, and there is a difference of in the node positive patients, those called as high risk, by CanAssist breast, the DRFI is at 76%, as against the low risk where the DRFI is at 91%. So there is definitely huge difference in the DRFI in the node positive premenopausal stratified by CanAssist breast as low risk.
Okay, this is good to know, because this is again something that we would be interested in using in our clinical practice. Again, I think being as contrary people as most physicians and oncologists are, we won't take it as the only truth, but certainly it is something that we would be interested in looking at. So if I can cut back to Dr. Julka, sir, so where do you see the deficiency, or where do you see a felt need for oncologists, which we can tell Dr. Manjiri and say, look, hey, this is what we need from you guys, and you need to tell us something what we want to do, but we need help from your side. Where do you see the deficiencies, or where do you see the felt needs right now in oncology, in breast oncology? We'll stick to the adjuvants and neoadjuvant.
Yeah, first and foremost is what she's doing, CanAssist, for most of the patients, and if they come up with data for node positive also, it would be really good, because we want the data, validated data for node positive. That means N1 disease. So basically, as you said, hormone therapy also, if any test develops, it would again give a boost to the CanAssist program. And again, we would like to, share the data. Then what the other people are doing, going in for breast cancer index. For people say if the risk of recurrence is low, then you give hormone therapy for 7 years. Otherwise, give it for 10 years. One of my patients, without consulting me, took the hormone therapy for 20 years. And afterwards, she came and said, I'm perfectly all right. And that means this is a hormone dependent tumor. And you never told me to take it. But I said, data is not there for 20 years. And how can I tell you to continue taking it? So she kept on taking it, and she's perfectly all right. She was treated in 1995 in AIMS. So ER/PR positive, HER negative. And so if a patient can take for 20 years and be all right, this gives us just a glimpse ki how much hormone therapy is needed actually. We go according to our protocols, according to breast cancer index, clinical scoring, and like prognostic scoring, all these scoring criteria. But clinically, if you see, most of our patients who have been taking for 5 years are still alive, and maybe 7 years could be for low risk and 10 years for high risk. That could again give us, the boost for most of our patients who are living longer. Because, and secondly, what I wanted to share about the abemaciclib, and we have a Natalie trial also, which we didn't discuss. Probably Vamsi, Natalie
Ah,
trial ribociclib.
we don't have the full paper of it, so I'm not still
Yes,
discussing it. We only have a
yes,
presentation. So, I want to discuss that paper very badly, but I don't know why the full paper hasn't come out. Unless I
hasn't
see the
come
full
out.
paper, yes, I really
Yes,
want to
yes,
know why the subsets are working the way they are, because they have a much broader indication. Their
broader
usage is
indication.
much broader. They have used it
Yes,
in a lot more patients. So, does it impact
right.
all? So, that's the reason I'm not discussing it, sir. There's a very
Yes,
valid
yes,
reason why I'm not discussing it.
yes. That is why I was
And
going to tell.
ASCO was nearly 4 months back. We still don't
Correct,
know.
correct, 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 correct. Six
So we
months,
don't
no
know
paper
why.
is something. Yes, yes.
Natalie, I would have expected, when
Correct.
a paper doesn't come 4 months after the oral presentation and something as prestigious as Natalie, you're worried,
Yeah.
has the peer reviewers found something that's, horrendously wrong, and this is why it's not getting published.
Yes,
Maybe
I
they are
think the
yes.
waiting.
troponin was.
They're
Uh,
they're
Yeah.
waiting for
They're waiting
more
for SABC
results.
Yeah, I
They're
don't
analysis.
know
wait.
where they are, but there's something going on. I mean, we expect it to have come out. It's like troponin.
it is,
Troponin, the press
Yes,
conference came a few months back. Yesterday it came, and then again, the results are not, well, let's say, earth-shattering, to at least be
yes,
fair
yes.
about it. So, that's how it is. So, Dr. Bharat, if I could ask you the same question, where do you see the deficiencies, a kind of place where we need more work, where we would like to have some data from the clinicals, from the lab side, you can give ideas
see,
to Dr.
as
Manjiri, where
yeah,
we.
as far as breast is concerned, the Dr. Manjari's uh, platform like Oncotype DX is very binary. Oncotype DX is not binary. We have to say it's trinary, but this is very binary. Low risk or high risk, you are very clear. This, like Dr. Julka said, there is no intermediate risk and score changing over time, which confuses us. So it's very important. But that is to tell us chemo bar no chemo. Again, binary. But with when all this started, when we go back, what I told you, in 2007, 8, we were thinking of what type of breast cancer, what, or based on gene expression profiling, and that is a very intensive sort of testing. But when we look at oncotype and then Dr. Manjari's platform or anything, it is based on the proliferation markers that are there in the breast cancer, and then you're putting it into a basket and then finding chemo versus no chemo. Similarly, now we should look at all of Dr. Manjari's subsets and everything, and look at what is luminal A and what is luminal B, especially in breast cancer, because we all know that we have patients of breast cancer who have got extensive metastatic disease, who have been started on PAL-base, when PAL-base came in 2014, and 2023 they're still in complete remission after 9 years. I have patients like that. I have a cohort of some 20 patients walking around, and I'm amazed, whatever it is, 9 years, the first patients, they
Yeah.
still, and it's free. So nowadays they don't even come and do their CBC, they know how to manage their PAL-base. It's like that. So we know even in metastatic breast cancer patients, there are patients who are surviving long. So a lot of patients in adjuvant setting actually need not take the chemotherapy. They can just go on, with, like sir said, with longer duration of hormones. And that may be the patients who are, luminal A versus luminal B. Uh, uh, that is a different stratification, subtly different. Oncotype DX and CanAssist are chemo versus no chemo. But the real low risk breast cancer versus high risk breast cancer and hormone positive is, I think, to my mind, it is luminal A versus luminal B, which after the mama print and the blueprint, which came, as a pad test, then nobody is now doing it or talking about it, or we've forgotten it. Maybe that's something we have to look into, especially for node positive women, where we can maybe avoid chemotherapy in the adjuvant setting also.
Interesting. So, coming to this same thing, Dr. Manjiri, where do you see the role of AI? We're not talking of aromatase inhibitors here, but where do you see the role of artificial intelligence? Because you have this huge bunch of data. More than us, I think the AI will really help you to pass through that data and answer some of the questions that Dr. Bharath is posing to you. Are you using AI actively? Where do you see it being used in the future? What are your thoughts on that?
Yes. The, the good thing about AI is, it can really look at many different aspects than currently a human eye can. For example, today we are looking at just CanAssist breast itself. We do immunostaining for immunohistochemistry for 5 biomarkers. We are looking at only certain aspects of those stainings. But with deep learning methodologies, which are also AI based, actually there is a lot more that a stain slide can tell you than what we are doing today. So that is where we really want to go with CanAssist based platform. Really develop deep learning algorithms for the same 5 biomarkers, but maybe that will be able to push the NPV, which is real world NPV today, is about 96%. Maybe it will go to 98%. So that is really something we are looking forward to do by using AI. And we are also looking to develop additional tests for triple negative and for ovarian cancer patients, different questions. But again, those will be AI based algorithms. And now the AI has also become really, there are many more newer, my statistician tells me, there are so many more cutting edge algorithms, cutting edge methods of looking at AI. So that's the other two tests will use those algorithms to come up with even more accurate tests for those two cancers where there are actually no tests available. So I have the good thing about AI is it can really handle it. Is the more data you feed it, the more accurate it becomes. Only thing you have to be very careful of the quality of the data. And so long as we maintain that quality of the data, over the 5 years, the patient samples that we have, not only the validation, but even prospective, those additionally we can add to the training set and really make a more robust test, maybe in another 5 years, where we will have the 5-year data of these existing patients. So these are really the steps that we look forward to taking by really harnessing the potential of AI.
I think that's the really nice way of putting it. I think we have a lot to learn about AI and a lot to, I think this is the way we are discussing IO now. Soon we'll be talking of AI maybe. So I think it's been a very wonderful discussion, but we are running out of time. So I think the last 2 minutes, just Dr. Bharath, your final comments. Where do you see us, say 5 years from now? Let's not talk of 1 year, 2 years. We might be still discussing the same topics. 5 years down the line, what are we going to be discussing? And your thoughts for the future?
I'm sure I'll be wrong if I, predict anything for 5 years. I'm not even sure about, 1 year from now. Truly and honestly, Vamsi, we are just a few years apart in training in medical oncology. I think I hardly treat any tumor the way I was treating when I was trained in TMH. Every tumor, the training is different, and I in 10 years, I think, to my mind, or 5 years to my mind, we will be more sure on who needs chemotherapy, who does not need chemotherapy in breast cancer. That maybe will be more sure, and thanks to people like Manjiri. Second thing, will be more sure in next 5 to 10 years is the duration of hormone therapy, whether it's 7 or 10, and who it is for 7 and 10, that I think. Third, we may be more sure about, whom to give an additional CDK4/6 inhibitor vis-a-vis not. So I think these things may happen in the hormone positive subset in the adjuvant setting. In the metastatic setting, I think there is no limit, there is no ceiling, there is no sky. Things are going to develop. We are going to get better hormones. We are going to look at better endocrine resistance patterns, better, second line hormone therapies, third line hormone therapies probably, and we are going to have very good antibody drug conjugates, both in the triple negative setting and in the HER2 positive setting. So I think there's going to be a huge, growth in the metastatic setting, which will all improve the, sort of at least the quality of life for breast cancer patients, and some definitely some amount of improvement overall. So it's what I believe will happen. More drugs. Cost, don't ask me. I don't know.
Okay, I will not ask you about cost. Dr. Manjiri, your thought on
Actually,
the next 2 years, and then Dr. Julka, and then we'll wind up.
yes.
So Dr.
My
Manjiri,
thoughts for
your
next,
thoughts.
yeah, my thoughts for next 5 years would be, I'm very optimistic. I'm not only looking at the drugs that Dr. Bharath has already mentioned, but I'm looking for methodologies where we can actually see whether the drug is working on that patient's tumor tissue. So really come up with really smart radiological tools, or something where we actually can figure out, yes, this particular tamoxifen is not working, ESR is mutated, or whatever may be the reason why the patient could be progressing, and really correct it right away, and use something else. Maybe endoxin is, I mean, the in between derivative is there, not there, too much is there. So really look at all of those technologies, improve our, not only our drugs, the efficacy, the specificity of those drugs, but also way of assessing whether it is something is working or not, because so many patients progress on Herceptin too. So how do we tell upfront whether this patient would respond to Herceptin, TDM1, whichever may it be? But develop tools to measure the response.
Dr. Julka, sir, your final words.
Yes. Actually, more and more people would be getting gene expression profiles in the future. And I suppose that genomics, transcriptomics, like, RNA sequencing, and we have metabolomics coming up. So all these tools which are coming up, they might help us to reach to a correct diagnosis and help the patients much more than what we are doing with only clinical profiling.
I think personalization is the way to go. More and more, we are
Yes,
going to see personalized treatments, and we are going to hear about how
personalized
we are going to treat each individual patient rather than the whole. So I think that's where we are headed to, and
precision
I'm
of
sure with the help of, absolutely, with the help
precision
of
oncology.
dedicated scientists, yes, with the help of dedicated scientists like Dr. Manjiri, I'm sure we'll be there soon. So thank you, everyone. That was a wonderful discussion with everyone, and it's always nice picking the brains and seeing where the future holds. And hopefully, in 5 years, whatever we have said will come true. So thank you, everyone, and over to the organizers.
Thank you, Dr. Vamsi, for nice panel discussion and for having all of us.
Thank you. So good night, everyone, and we'll see you again,
Good night.
hopefully in a couple of years. Thank you. Good night.
Thank you.
Sure. Thank you. Bye-bye.
Good night. Bye bye.